So what we wanted to do is that we really wanted to be able to showcase across California there are incredible pilot programs and initiatives that are going on in care coordination and integration. And the word that Sandra got when she was doing the planning for the policy forum is that there are an abundance of healthcare reform and ACA preparation conferences. And what really folks want to hear about are the nuts and bolts. And so we have 7 different counties that are going to be talking from their own perspective about the nuts and bolts of their care coordination and integration initiatives. What we're going to be doing is that we're going to have each county is going to go ahead and introduce themselves. And we know that there will be questions at the end of the presentation. We don't think that we're necessarily going to be able to get through all the questions. And so let me just tell you which counties are going to be presenting, and then we're going to give you an email so that you can actually email questions to us, and we are going to get them to the county so that all of your questions get answered. So we have Glenn County, San Mateo County, San Diego, Los Angeles, Kern, Alameda, and Modoc. And we have 3 different groupings. So we have initiatives that have been funded through the SAMHSA funding. We have initiatives that are funded through the MHSA Innovations dollars. And then we have an initiative that was supported through CIMH through Quality Improvement Learning Collaboratives. And then the last thing before we turn it over to Glenn County is that there is going to be an Innovations and Integration Summit. It's going to happen May 22nd and 23rd. Be a lot of opportunity to be able to have more discussion. And so if you are really interested after this conference, make certain to take these dates down, and we have flyers out so that you would be able to attend that. Scott, I'm going to turn it over to you.
And as we get started, just to let you know, we're going to let the presenters introduce themselves just in the interest of time. So take it away.
All right, so according to the clock, I should be done. So, good afternoon. My name is Scott Gruendl. I'm the Health and Human Services Agency Director for Glenn County. So we're a combination of 8 county departments, and I actually ran the health department and the welfare department separate for several years until earlier in the month of January. So I'd like to talk to you about the Healthcare Collaborative, which is essentially our bridge to health at a time when we were running out of money and trying to figure out how we would get to 2014. We applied for a SAMHSA grant, and we're successful for $2.5 million over a 5-year period. For integrating a primary care service into our behavioral health clinic. And additionally, which I won't get into today, we also received an additional grant that's a sub-grant of that SAMHSA project that funded our EHR, because we had originally funded it through the MHSA and it failed. And we had gone with a system that was just simply too complicated for a small county. Actually, it was a group of small counties that did it as a JPA, and we are killing that JPA next month. So that grant gave us a second chance at our EHR, and it's been successful since. So in Glenn County, we partnered with a federally qualified health center. We actually put out an RFP for our partner. We had 3 proposals, FQHC and FQHC Lookalike, which was our Indian health program, and then our county hospital, which is not truly a county hospital. It's a foundation hospital, but it was the county hospital, and most of the county electeds are on its board. And primarily what we were trying to do is just simply create a medical home for our mental health consumers. And as I mentioned, primary care and a mental health clinic, but that mental health clinic also happens to be co-located with a substance abuse disorder clinic as well. So all 3 of those services are provided in a single location. And you'll see here phase 1, 2, and 3. Something I've noticed between small counties and big counties is small counties have a tendency to write. Big counties have a tendency to do really nice graphics. Not that I can't do those, but we probably just have older software. And these phases were not part of the grant. This was our learning experience. We could not simply move into getting the licensure that we needed, so we started by transporting our clients to the FQHC to ending with a couple exam rooms in our mental health and substance abuse disorder clinic and actually providing the service there. I think one of the things that has made the project really successful is who we're actually working with in the project. So our primary care provider is a physician's assistant, but he also is an MFT. He was the third individual that we worked with in this project until we reached somebody that worked with us really well. All the supportive staff, the nurse, case manager, those types of folks are actually staff of my department and support him. At the end of each day, all those staff meet together and review everything that occurred that day, and that really helps with coordination. But a more interesting thing is we got Dr. Mark to do what we call wellness prescriptions. So he actually writes prescriptions for physical activity. And then the other thing there, wellness in all locations, is basically a positive outcome from this that we did not expect, is just wellness through our entire organization. So there's a wellness component regardless of whether it's substance abuse or mental health or primary care. We've got some kind of wellness activity occurring in all of our locations. And that goes for the reverse. So primary care helped transform the mental health and substance abuse disorder areas, but likewise we transfused MHSA principles into primary care in that all of our wellness activities are actually conducted by folks with lived experience. We call them peer mentors and coaches, and about 20% of our staff are actually consumers. And this next one here probably should have been on the previous slide, but so not only do we have these daily meetings between the immediate delivery team, but we also have meetings on a weekly basis with everybody else that would be involved with that patient, not necessarily directly on the primary care team, but additional folks that might be providing support. So some of the challenges, just a lot of care and feeding, constant care of feeding. So I've become a personal friend with the CEO of the FQHC. He and I are counties apart because it's a 6-county FQHC, which that unto itself was very important to me because it's a very small county, 28,000 people in my community, no managed care, and we'll get it this summer. I'm really concerned about being able to latch onto a larger fish. So an FQHC that stretches across 6 counties is really helpful in that regard. Him and I meet on a regular basis. We go out to lunch. We tour facilities together, that type of things. Just spend a lot of time together. We're at 2 different places when it comes to our electronic health record. We're fully implemented. We've met our meaningful use, whereas they're just starting to implement, and unfortunately, since we're one of the smaller counties out of their 6, we're at the end of their implementation cycle. And that just poses serious problems for us in how we track and share records. So we get information faxed to us, and then they got to do a HIPAA log, and so it's pretty archaic and old-fashioned, but once the EHR is up and running for them, we don't expect to run into those same types of issues. Licensing has probably been the most difficult thing for us, and we're on track to actually be fully licensed before the grant runs out, because that is our sustainability plan, to be able to bill for physical care in the mental health and substance abuse clinic. And we've built staffing on both sides. So depending on how things happen moving forward, we could cross-bill between the 2 organizations based on whose staff is providing what. And right now, we're just down to the detail with HRSA. Like our mental health and substance abuse clinic is a very old building, and we're going through a Title 24 audit right now to meet some HRSA requirements. But we're well on our way, and I appreciate larger counties that have helped us with that, including Alameda and San Mateo. And as I said, we're on our way to sustainability, and we should be able to cover all of the costs of the grant within about the next 12 to 14 months. So some good unintended consequences was we started a chronic pain management just based on input from the folks that were in the program and the work that we were doing with all of the wellness programs, that we were actually able to move a couple dozen folks into a pain management program in which we transitioned them off of prescription medications into physical activities, and had a lot of success with that. And the real neat thing about that was a consumer-driven idea, and most of the activities, as I mentioned before, are consumer-provided, and it just worked really well. And our medical staff were very helpful and cooperative, and were able to get things back on track when folks slipped. And so we were asked to do a client story for today, and that's just basically what the story is we had a particular client that had been using pain medications for a couple decades, and through this unintended consequence, they were actually able to transition off of their medications 100%, and they just can't stop talking about it. And that's kind of what has helped grow the program. When we say, consumers wanted it, consumers created it, and consumers are promoting it. So a while back, we were trying to figure out how to share information with child welfare, between mental health and child welfare. So we came up with these report cards to show progress of child welfare children in the mental health program. And over the years, we transformed that report card into other mechanisms for sharing information between our programs. So in the healthcare collaborative, we created the individual wellness report, in which a number of criteria are established at the time that the individual enters the program, and then we monitor that over their time that they're in the program, and we tailor it just for them. So it's primarily designed for the individual consumer to track those particular health indicators that they've decided to track in conjunction with our staff. And then their case manager also works with them to monitor that. So it's just been a really good way to help make something simple for them to monitor and measure and see their own success and be directly involved with that. And so again, the wellness reports are just something that has a tendency to permeate throughout the organization. So one of the things the wellness reports are based on is our system-level outcome data. So there are a number of indicators that we're required to track as part of the grant, which would be the NOMS data. And the wellness reports are built off of that. So as we begin to drill down into that data, I'm just going to show you just two items. And one of the things that we do with that system-level data is we group them by cohorts. So there may be 8 to 12 individual consumers assigned to a case manager, and so we would group them in that way and produce the reports for that grouping, so that the case manager can actually monitor their progress. And we're doing them at 6 month increments. So I wasn't sure how good that would look up there, but you also have it in your binder for today, but unfortunately that's not in color. So just real quick, what's interesting here is we're tracking use of alcoholic beverages, and the lines that go all the way out to daily or almost daily, which would be on the far right. Those are folks that have just entered the program, so that would be either a 6 or 12-month increment. The lines that are shorter to the left of the dotted line running down the left side of the screen is that is the never demarcation point. And the longer an individual has been in the program, the less likely they are to use alcoholic beverages on a regular basis. And so, in one quick snapshot, the case manager can see what's going on for his particular group or her particular group and be able to hone in on that. Now, we can't say the same for marijuana. So this is the outcome data for marijuana, and I really should have spent a few moments with the evaluator to ask what was going on here. and I didn't do that. And when I was looking at this the other day, I'm like, what, how am I going to explain this one? But I'll leave that up to the medical professionals that are going to come after me. That's the good thing about being first is there's plenty of room for plenty of room, and this is my last slide. So I did talk about the wellness reports, and in the packet that you received today after this PowerPoint, there are copies of the wellness report. You might need a magnifying glass to read it. And then a couple pages back is also the abstract of the project itself. So in conclusion, it's just been amazing to have a partner in primary care. There's so much that we do now. We're building capacity on a whole bunch of other fronts that has nothing to do with this project. So it's just been a great relationship. We're teaming to deal with implementation of managed care in the remaining 28 rural counties, which for small counties can be a really scary thing because our introduction to managed care has been a nightmare for us. So it's good to be with folks that get that and get it better than we do. And it's just been a wonderful symbiotic relationship, and I hope it continues to grow. And with that, thank you very much.
So just want to say thank you, Scott. And just to remind folks that have just walked in the room, Jen and I will put our email up again at the end of the session. We've got a lot to cover. The San Diego folks can start coming on up. Oh, San Mateo, sorry. I got everybody prepped wrong. But we will post all of this material, and I think you'll be able to see it a lot better on the web. And we'll link you to the folks that are presenting.